So it gives me great pleasure to introduce Professor João Carlos Wink, who is an associate professor at the University of Porto and is, I'm pleased to say, the chair of the Non-Invasive Ventilation Assembly at the ERS. And he's going to share his experiences with regards to remote monitoring today. Thank you so much for being with us.
Thank you, Michelle, for inviting me.
Lovely. Now, I know in your practice you utilise remote monitoring, and I just wondered if you could explain the driver for you using remote monitoring within your home mechanical ventilation population.
Well, I think pandemic times have really fueled a lot of telemonitoring, at least here in Portugal. But I was using telemonitoring already. So what has done this pandemic has really increased the figures. I think that now much more people are using telemonitoring than before. For me, I think that it's important to use telemonitoring at the initiation of all mechanical ventilation. I think that it gives you a better approach to titrating support and being proactive in this phase, because it's so important the first weeks of treatment that if you are really monitoring how the patient is doing, how many hours is he with a good fit of the mask. So it's really as an enormous prognostic, is an enormous prognostic factor, and it's a very good indication for the compliance of therapy. So I think that we have gained a lot of insights from telemonitoring at this phase of initiation, and also to make sure that our patients is controlled. So I think that telemonitoring has avoided a lot of face-to-face interviews and evaluation at the hospital, and we can do by trial and error a lot from a distance, and that's really very good for these chronic respiratory failure patients.
Yeah, I think one of the key things to know is, do you have a patient that takes home the device and just sticks it under the bed and never takes it out and never tries it? Or is it that patient that puts it on every night, but they're only managing to use it for an hour? And what's the barrier for them? And you can pick up on that, because it is so important that if they don't use it at the start, the chances of success are so much harder down the line. I know that when we took part in some remote monitoring trials, the team were very apprehensive about actually instigating it for various reasons, about workload, what their responsibility would be, etc., etc. Did you have any barriers, or was it well adopted?
Yeah, that's a very important point. I agree with you that the main barrier for that is the workload. I think that we should have some extra professionals to help us out here. I would call them like digital assistants or whatever, or telemonitoring assistants, because I think we are going to be overwhelmed by the information that comes out of the platforms. Of course, I think that the previous situation was that I was receiving a lot of PDFs from the companies or from our staffing, and I would just go through all these files, opening the files and etc. I think that now with these platforms, it's so easy to get into the patient information and getting out the details and doing this, like 5 or 10 minutes. But when you're talking about hundreds and hundreds of patients, that can become really very time consuming. So I think that the platforms in the future can be, having artificial intelligence or whatever to to help us out here, because otherwise I think that we will need more people taking care of these big data that we are just having in the future.
Yeah, and I think that with patients not coming to the hospital and the fact that we're virtually reviewing them and saying, how are you getting on? Being able to go into that record in real time and see what's happened can be incredibly useful, especially if it's like, oh yes, honestly, I use it every night, but I wake up with headaches in the morning and my husband complains that I'm snoring, and you go in and you see, well, actually, you've only used this for 20 minutes for the last year. It can solve a problem, or you can get more information. That said, from your perspective, what would you say are the parameters that are needed to start a service?
Yeah, I think that the majority of the parameters are already there. So I think that all the platforms include the most important parameter for me, and the ones that you mentioned. So compliance, so the number of hours of usage is quite important. Also, the graph is so important to see if there is some interruptions during the night. So you can see there are some lags in between the bars. So it seems like there is some awakening of the patient that must be from some reason for leakage or wherever. So what I just at the beginning, what I look immediately is about the number of hours of usage, and also how constant is this usage. Is there any interruptions, any parts of the night where the patient takes out the mask? And that can be really a starting point for the discussion about how well is the tolerance to the therapy. And then the leakage, that also is something coming out from the figures, and also the apnea hypopnea index, with which we have to be a little cautious about, because we know that the correlation is not 100%, but still it can give us some good information about, is it obstructive airways disease, or it's some central events. I think that some of our devices are pretty good in differentiating these kind of events. And also, I think chain Stokes breathing is something that we probably need more studies. Some of the devices can also give us some information about this, which can be quite useful, especially if you have a complex sleep apnea with central and obstructive, and then chain Stokes breathing. So it can be quite useful, but still I think we don't have a lot of information on the reliability of these points. And what else can we have from the monitoring? So of course that if we can add on some biological parameters, so some saturation, some end-tidal CO2 that some of the devices can also include, or even from some brand new devices, we can also use the belts, which can be quite important, especially when you're titrating remotely some difficult patients that have some asynchronies, and you have to understand what kind of asynchrony it is, and you want to have the more parameters, you want to better characterize which kind of events are you seeing. But as I said before, I think that the more complex the monitoring, the more time consuming. And I think that I've spent, and maybe you have also spent, like 1 or 2 hours looking at tracings from the patients that you're going to see next week or whatever, because it's really sometimes quite time consuming.
Yeah, I found that you can get away with the basics for some, and that you will want to go and look at some in more depth, but it's not always essential that it's there at the start. I think a key thing that clinicians want to know is there a patient group or a type of patient that particularly benefits from this? Because it's like, do you target the whole of your population, or are there a specific group that you should be targeting if you're just getting used to remote monitoring?
Wow, that's a very difficult question. I think that COPD is probably one of the most important patient population that we should have a closer look, because we have the indications are robust right now, but still the tolerance, the compliance is not super. We have a lot of patients that don't tolerate ventilation, and so I think that this subgroup of patients, I think telemonitoring and the more you can get from telemonitoring, the best. And maybe the patients that you think will be at risk of compliance. So I think maybe the elderly. Today I saw a patient in my clinic that was a fibrotic patient with post-COVID, so very weak, and he was hypercapnic, and I tried to titrate him at home, but it spent like 20 minutes on the vent. So it's quite important that you have this picture as soon as possible to make sure that you can intervene as quickly as you can. And I think that these more complex patients, I think that the neuromuscular patients are the ones that are easier to titrate, because and I mean and also the restrictive, they're probably the patients that respond the best to the therapy and are the more compliant to the therapy. But we know that some particular patients maybe need some closer look, like ALS. And I think that maybe ALS, we should have some closer look as well, because of the risk of upper airway obstruction. And this is a complex disease. And so maybe the more complex patients are the ones that we should target, in my view.
It's always interesting that your mindset is for those patients that aren't using the device, because you want to make them use it. But likewise, it's what do you do if they suddenly go from using it 12 hours a day to 24 hours a day? And that information is equally useful.
Absolutely, absolutely. And that's something that we commonly see in these rapidly evolving neuromuscular diseases like ALS. So it's so important to have closer looks, even on a weekly basis, because sometimes we see disease rapidly deteriorating to the point that we have to decide upon doing invasive ventilation or increasing the assistance to the cough. And I think that I agree definitely with you that having this information on a regular basis is so important, and that allows you to avoid having the patients to visit the hospital on a 3-month basis, which is the traditional way, because sometimes, having this information after 4 weeks or 1 month is so important to see what is going on when about the compliance. Yeah,
definitely. And I think that although we're not talking about COVID, but patients have learned that we've been managing them in a different way, and they don't want to go back to fully attending the hospital all of the time. They understand that they're going to have to come. But sometimes if it's a routine visit, everything's fine and all of the parameters are fine, and you can get that information digitally and remotely, then that has a huge impact on their well-being, that they don't have to get up and travel for an appointment where they spend hours waiting to be seen in a very short period of time and traffic getting home. So I think that it gives us the opportunity to remodel our services in a positive way.
Absolutely, 100%. Yeah.
Thank you so much for spending the time talking to me today. It's been a great pleasure to have you with us.
Thank you, Michelle. It's really a pleasure speaking with you, and thanks for inviting me.